Oh, good morning, guys. So I do a lot of refractive cataract surgery in my practice, and this is one of my keys, obviously, is nailing that planar result. But I'll tell you kind of all of my keys, in addition to just the biometry. I do work with many companies in ophthalmology, including Hogstrite, but also including their competitors. My first one, obviously, is to increase refractive accuracy, because the goal of refractive surgery is happy patients. And happy for me means the results that you give them exceeds the patient's expectations. I always do a Dell survey or some variation of this to figure out what the patient wants. And even though I can figure this out, still I must hit my planar refraction. Now this is obviously my goal of 0, 0, 0, 0, 0, 0, and perfect case. But it's rare enough that when this comes up, I tell my tech, quick, grab my camera. Now I wish I could nail every patient like this, but we're getting close. And I think if you're at least within a half diopter for sphere and cylinder, that's a pretty good start. And there's no shortcut, unfortunately. You have to really hit that target. So here's just a summary of my biometric data. And actually, there you go. There's my 1.27 diopters still on the right and 1.6 on the left in my cornea. But magically, luckily, I have no sill in my refraction. For corneal biometry, of course, we want to know the corneal power and also the corneal astigmatism, but also want to know the corneal pachymetry, because I have to be able to correct the astigmatism, like with a limbal relaxing incision or maybe a toric lens. The difference between an unhappy patient and a happy patient, no matter which lens you're using, is the difference between spherical, which is here, and astigmatic, which is there. Since I'm doing these LRIs, I have to be able to know the corneal depth ahead of time. So previously what I was doing was measuring every patient with a manual pachymetry measurement, because I want to do my LRIs as a percentage of corneal depth in order to have the best effects, like 90% of corneal depth. And then remember, my LRIs are actually placed in the peripheral clear cornea and not actually at the limbus. Another trick that I do is I actually trace my fixation ring with the diamond blade footplate so that I get a perfect arc every time, so I don't have to freehand it. As an example here, there's a patient with an LRI done here at 90 degrees after implantation of a presbyopic lens. Another thing in the keratometry is we want to have multiple measurements, and this is done at 2 ring sites. This is a 1.65 and a 2.3, so the average of this is just under 2 millimeters. Now we actually want to know the central corneal power. So the closer or narrower optical zone is, the better. So our manual keratometer is only about 3.5 millimeter optical zone. Our Hogstrite's a much tighter zone. The benefit from this is particularly important in patients with post-refractive eyes, post-LASIK eyes, post-RK eyes, and unfortunately in my practice, that's 40% of my IOL volume is post-LASIK, post-refractive. It's part of the neighborhood in which I practice. Everyone's had LASIK. And so this is an important measurement for me to get more accurate Ks. When we're doing our LRIs, we want to make sure that we also take patient's age into account. You know, if we're doing, a patient has a younger patient is going to have less effect from LRI, and then also pachymetry. So if the patient has a thicker cornea, I have to know that because my LRI will have less effect. If they have a thinner cornea, I don't want a perf, plus my LRI will have more effect. So pachymetry for the cornea is an essential measurement for any presbyopic lens patient. And there's an example of where my LRI is. So I sometimes get surprised though. I had a patient who came in for a presbyopic lens. She really wanted a multifocal. And you can maybe overlook some of the guttae here in the cornea, but when I looked on her pachymetry measurement, it was 610 centrally. So I figured, wow, 610 microns centrally is awfully thick. Let me just do an endothelial cell count, and I was quite surprised when an endothelial cell count came out to be 839 cells per square millimeter. So she certainly has fused dystrophy, though her cornea is not edematous. And this is not a patient where I'd want to put in a multifocal lens. She's better off with a monofocal. Here's another one. Patient came in and his pachymetry is 466 with a lot of irregular astigmatism. Well, clearly, this patient's not appropriate for a presbyopic IOL. This keratoconus needs to be addressed first. Here's a patient who had irregular Ks, normal pachymetry, but very irregular Ks. This is one of my patients with map dot fingerprint. In fact, hard to miss it. Here's a map of Florida. Here's some dots, and there's a fingerprint right there. Here's a patient who had Ks of 34 and a pachymetry of 380, very thin centrally. The tech forgot to write down that the patient had prior LASIK. Well, luckily I was able to see the LASIK flap edge and also the dry eye. This patient had 10 diopters of prior LASIK. Or a patient with Ks that are shallow, 37, but with a deep ACD, and so that's why you need to have that ACD measurement. For the lens biometry, we want AC depth, plus we need lens thickness, plus we need white to white. And I'll tell you why we need all that. Here's a patient of mine where the axis length was normal, slightly myopic, but the AC depth was very shallow. And I learned this from Alan Crandall, who taught me that if the AC is shallow in the presence of a long or normal axial length, that's because the zonules are so loose that the whole lens iris diaphragm is pushed forwards. So in this eye, with all this pseudoexfoliation material and the shallow AC, I know for sure this is going to be a loose zonule case. Here's a patient who came in to see me for a traumatic cataract. And you see the traumatic cataract is this kind of sectoral area here. A little bit of a sneaky. It doesn't look too bad. But when I look at his measurements for AC depth, he's really deep. I wondered, why is that? So I have the same patient. I said, look to your right for me. And he looks to his right. Oh, very nice. So at this point, we see at least 4 clock hours. And one of my rules is if I see 4 clock hours of zonule loss, that means it's at least 6 in the OR. Whatever you see pre-op, it's always worse in the operating room. And you can see this little iris pigment here is stuck in a tongue of vitreous. So he's got loss of zonules for 6 clock hours, vitreous coming forwards. This will be a tough case. And it was all tipped off to me because he had an abnormally deep anterior chamber. We also need to know lens thickness, because lens thickness can vary as well in certain anatomic problems or conditions. But also we need to know lens thickness in order to use our Holiday 2 software for a more accurate lens calc. A normal lens thickness should be about 4. This patient had an axial length, or normal axial length, but a lens thickness of 5. And when you look at the patient has a posterior polar plus a posterior lenticonus. Unusual deformity. These are all my patients. Here's a patient for cataract surgery, and his white to white was very small. Small white to white. This is clearly an abnormally developed eye. But here's a patient with a very large white to white. So clearly all these eyes aren't the same. That's a 6 millimeter optic. And yet it's perfectly centered in the visual axis. This is another point that I'll bring up, is that you have to know the centration of the pupil, its position, in order to properly put your lens in the eye. For effective lens position, why is there any variability in our lens calcs? If we know such exact Ks and exact axial lengths, there should be no variability, right? Well, the answer is because you have a guesswork in figuring out the effective lens position. So where in the eye does the lens actually sit? The earlier generation formulas, the Hoffer Q, Holiday 1, and SRKT, all make an assumption. And that assumption is if you tell me your Ks and your axial length, I can guess where the effective lens position is. And it kind of makes sense in most eyes, but you'll get fooled. You get an eye with a flat K like an RK eye, but a long axial length, and the formulas think the IOL will sit too far anterior. So it drops the IOL power for you. And then post-op, your patient gets a hyperopic surprise. So this is an example of a non-prior surgery eye, so a virgin eye, but the patient had a crystal lens. And you see the gap here between the light reflex on the iris and the light reflex on the lens. That tells me the crystal lens is posteriorly vaulted. And so figuring out this effective lens position is important, and that depends on white to white, AC depth, and lens thickness. And this is why when you have the Holiday 2 software from Jack Holiday, you've got 7 variables that need to be input, including lens thickness. And that tells you a more accurate, effective lens position. Pupil biometry is important, which means size as well as centration. Remember, that's the center of the cornea. But that's certainly not the center of the pupil, which is probably here, and the center of the visual axis is probably a little nasal to that. So this is actually my eye, my right eye, and I can see that my center of my pupil is here, and the center of my visual axis is even a pinch nasal to that. And if you look at my eye again here, clearly this is my cornea. The center of my cornea is probably here. Center of my pupil is there, and center of my visual axis is there. This is important when I set up lenses like a multifocal. Here's a Technics multifocal. You notice I orient the haptics at 12 and 6. And the reason is, so I have the haptics at 12 and 6, I can nasally decenter the lens. Decentered from the capsular bag, but very well centered in the visual axis. So here's the patient post-op, and we have beautiful centration of all the rings in the visual axis. Also for the Restore Plus 3, again, beautiful centration of the rings in the pupil as well as visual axis. Retinal biometry is also important because patients can have underlying disease that I may not see just with my slit lamp exam. So I want to know axial length plus retinal thickness. Axial length, of course, for the lens calculations, but also retinal thickness. And here's my retina, and luckily it's less than 200 microns. But if patients have diabetic macular edema, an epiretinal membrane, a pucker, a hole, macular degeneration, they're going to have an abnormal retinal thickness. And that's going to tip me off ahead of time that this is not the type of patient that I want to put a presbyopic or multifocal lens in. For lens calculations, right now you have all the software for your formulas built in, SRKT, Hoffer Q, Holiday 1, and soon to be you'll have the Holiday 2 as well. And the Holiday 2 is nice because it's a little bit more accurate, and particularly in the more challenging eyes. Small hyperopic eyes, post-LASIK eyes, etc. Remember, you need more variables though. So for Hoffer Q, Holiday 1, SRKT, you just need 2 variables, Ks and axial lengths. But for Holiday 2, you need a lot more input variables. And so the only machine right now that's available that will actually give you all of these, lens thickness as well as all the others, is going to be the Hog-Strite LensStar. My second key, besides getting good accurate refractive results, is really cleaning up the ocular surface. And I've been burned here before. Remember that corneal nerves are cut during cataract surgery, both without incision and also for LRIs. And this can induce some degree of dry eye syndrome. So I want to tune up the ocular surface before surgery. So any blepharitis should be addressed. Ocular surface disease, again, there's my EBMD patient. My third key is to really educate the patients. You got to figure out what the patient wants. If they want x-ray vision, you're not going to be able to deliver. So remember I said at the beginning I used that Dell survey? Here's an actual one filled out by a patient of mine last year. And it says personality on a scale of 1 to 10, 1's easygoing, 10's perfections, what are you? And he writes 10, and he writes OCD. Well, thanks for telling me. It's for obsessive compulsive disease. He also writes in quotes, largest optical zone, unquote, aspheric lens, yes. I'm not sure what that means, but it probably means he spent too much time on the internet. And this is the one that says, you're going to give me perfect vision, right? Sure. Got your perfect vision right here. I have 3 sisters, they're all doctors. 2 of my sisters are plastic surgeons, so I learn a lot from them. They tell their patients that you're going to look better after surgery, but you're not going to look like you did when you're 21. So you got to have realistic expectations. So this woman comes in for a blepharoplasty, forget cataract, she wants a blepharoplasty. If in her mind she's thinking, boy, after surgery I'm going to look beautiful, you got to say, no, it's just not going to happen. This is a more realistic result. So everyone wants to be young, but you can't always get what you want, as the song goes, right? So just set realistic expectations. My sisters tell their patients, look, you're going to look better, but I can't make you look like you did when you're 21. You're 65, I'll take 20 years off your face. So I copy them. I said, look, you're 65, I can't give you the visual function of a teenager, but I can certainly make you see a lot better than you do now. Under promise and then over deliver. So I say, if you want to drive without glasses, that's reasonable. Computer without glasses, also pretty reasonable. And even your cell phone. Reading a newspaper without glasses, in good lighting, at an appropriate distance, reasonable. Reading the words on the back of a packet of Splenda by candlelight in that romantic Italian restaurant, not going to happen. And I give a specific example of the Splenda packet because they remember it post-op. And a few of them can read it, and they'll send me a thank you card with a Splenda packet taped inside so I can read it. And that's great. That's my goal, is to under-promise and over-deliver. So in summary, my keys for refractive cataract surgery were enhancing refractive accuracy, probably the most important thing. If I can really get close to Plano, both sphere and cylinder, these patients are going to be very happy. And the key to that is obviously accurate biometry and accurate calculations with Holiday 2. I want to optimize the ocular surface, treat dry eye, blepharitis, EBMD. Remember, if they have dry eye and I tell them before surgery that you have a little bit of dry eye, it may become worse after surgery. Well, now I'm a genius for predicting it. But if I never said you had dry eye, even if you're a borderline and now post-op you have it, guess what? It's my fault for causing your dry eye. because they don't know. And then the third key is educating the patient so he can really under-promise and then over-deliver. So if you do remember only one thing from my talk, that one thing is you're only as good as your biometry. Thank you, guys.
Thank you.